Imagine immigrating to Japan at age 50, going to a PCP for an annual physical, and being told that you need to undergo upper endoscopy every 2 to 3 years for stomach cancer screening. After undergoing endoscopy for stomach cancer screening, you find out that you're very low risk for stomach cancer as you've never had a Helicobacter pylori infection, a common infection in people who've lived in Japan throughout their lives and which is known to cause stomach cancer. Would you be furious that the Japanese doctor did not inform you that your risk as an immigrant was very low and that you did not need endoscopy? All because he or she needed to meet the stomach cancer screening quality measure. We do the exact same thing with colon cancer screening to all low-risk people to meet the colorectal cancer screening quality measure in the United States. Welcome to PCP Lens, where we journey through metrics, money, and madness. My name is Sudeep Bansal. I'm a primary care physician in Connecticut, and I run my own medical practice. In this video, I'm going to lay out in detail the data behind colon cancer screening, explain why this data is not sufficient to warrant colon cancer screening in the entire population, discuss harms related to screening, and why making colon cancer screening a quality measure causes more harm than benefit. Buckle up. This is going to be a long video as we have a lot of information to cover. The colorectal cancer screening quality measure specifies the percentage of adults 45 to 75 years of age who had appropriate screening for colorectal cancer. Let's break down the quality measure into its individual parts. First is the denominator, which defines the total number of eligible patients for colorectal cancer screening, which is everyone between 46 to 75 years of age. Next is numerator. This includes patients that have had one or more screenings for colorectal cancer. Appropriate screenings include fecal occult blood test, stool DNA, flexible sigmoidoscopy, CT colonography, and colonoscopy. Out of these tests, stool DNA and colonoscopy are the most frequently used. Then we have denominator exceptions. In this case, people are removed from the denominator only if the examining doctor justifies that it's not medically appropriate. Examples include patients being on hospice or palliative care, death during the measurement year, diagnosis or past history of colon cancer, the patient is 66 years and older and living in a long-term nursing care facility, patient is 66 years and older and meets the criteria for both frailty and advanced illness based on specific ICD-10 codes that are defined by NCQA. Next is the reporting period during which the quality measure applies. This is generally between January 1st to December 31st. And last are the data sources that will be used to calculate the quality metric. These data sources are generally billing codes or may involve a manual review of the medical record to find the documentation and submit it to the insurance company. Recently, CMS switched to the Electronic Clinical Quality Measure or ECQM for colon cancer reporting based on the NCQA standard. As far as I know, the basics of this quality measure is still the same. Now that we know the details of the quality measure, let's analyze the rationale and if it's achieving its intended outcome. The rationale for colorectal cancer screening quality measure is based on the 2021 USPSTF guidelines, which recommend screening individuals between 45 to 75 years of age who are at average risk for colorectal cancer screening. Interestingly, the guidelines don't define low risk. Therefore, the way the guidelines are written, everyone needs colon cancer screening unless they're in the denominator exclusion criteria. For example, they're already diagnosed with colon cancer. The physiologic basis of colon cancer screening is based on the adenoma-carcinoma sequence. I apologize for my lack of drawing skills, but most of the high-quality diagrams are protected by copyright law. According to this theory, all colon cancer starts with a polyp on the surface, progresses to breach the colon wall, spreads to the surrounding organs, and eventually metastasizes to other organs. However, this is an oversimplification, and not all polyps follow this neat pathway. Before we look at the data behind colorectal cancer screening, we need to define colorectal cancer. The standard definition of any cancer is an uncontrolled growth of cells. But then the next question is, at what point in the life cycle do we decide that all growth is uncontrolled? To make matters more complicated, we can look at this definition from two lenses. The natural history of progression of disease, which is backward looking. So if we start with metastatic colon cancer that is causing symptoms, then we will attempt to define any polyp or dysplastic colon cells as either cancerous or precancerous. If you watched my previous video on what is a disease, you may remember me talking about the biologic pathway, which is my preferred term and is more forward-looking. To recap, the biologic pathway starts with etiology, leads to pathogenesis, biologic dysfunction, abnormal biologic markers, clinical symptoms, and finally disability or death. Now, this is still a simplistic representation of the complex human biology. Now, let's try to apply this pathway to colorectal cancer. Etiology could be genes, or exposure to toxins in the colon. This can lead to dysplastic cells, which the body's defense system may either be able to destroy or keep them in check. Next is biologic dysfunction, when the body's defense starts to fail and dysplastic cells start spreading. After this, some biologic markers may appear, such as microscopic blood and stool or CT scan showing a small growth of cancer. Finally, patients may start getting symptoms including pain, change in bowel movements, frank blood and stool, or signs of spread to other organs, which may then lead to surgery or death. Polyps can appear in the pathogenesis stage, and they may not grow, as the body's defense mechanism may halt their growth. The time between the development of a polyp to it causing cancer symptoms may be weeks to months for an aggressive cancer, while in other cases, which is generally the vast majority of cases, these polyps will never cause a problem. The challenge with the natural history of disease is that we work backwards from the definition of cancer, and this leads us down the road of identifying all polyps as cancerous or precancerous and to remove them. This creates several problems. Polyps far outnumber the number of cancers. Removing most polyps does not decrease the risk of cancer, and we'll look at this data a little bit later. It's very hard to predict if any polyp will eventually turn into cancer, and if it will it take weeks, months, years, or decades? Colonoscopy, especially with polyp removal, increases the risk of complications. As medical science advances, we need to start looking at biologic processes as they develop to really understand at what point should we intervene. Now let's look at the United States Preventive Services Task Force, or USPSTF, guidelines on colon cancer screening and the underlying data for their Grade A recommendation. I'm going to show you screenshots of published information from the guideline and then add on my explanations. The first screening test is testing blood and stool. Most of the studies are very old, and they used an older version of stool blood test called the Guaiac fecal occult blood test. These studies did show a decrease in colon cancer-specific mortality, not all-cause mortality, and we have no studies with the newer stool-based tests. These new tests are called fecal immunochemical or FIT tests, and they are much more sensitive. This increases the chance of false positives, which may erase any benefits seen in the old studies and may also possibly cause harm due to overdiagnosis. Next is sigmoidoscopy. Sigmoidoscopy is the only colon cancer screening test that has shown a reduction in both cancer-specific mortality and all-cause mortality. The challenge is that most of these trials were approximately 25 years ago, and medical treatment has improved since then. However, this is a moot point for sigmoidoscopies, as no one performs this test today due to insurance reimbursement challenges. Next is the stool-based DNA test, such as Cologuard. A total of 0 studies have examined the mortality benefits of stool-based DNA tests for colon cancer screening. These tests have been approved based on their concordance with findings of either colon cancer or advanced precancerous polyps on colonoscopy. Essentially, all these tests tell us is the sensitivity and specificity of the test based on the gold standard colonoscopy. Those of you who are statistically inclined will realize that the real-world performance of stool DNA tests depends on the incidence and will result in high false positive rate in low-risk population. So if the study is comparing stool DNA against the gold standard colonoscopy, let's look at what USPSTF says about colonoscopy. There are 2 high-quality prospective cohort studies on colonoscopy, mind you, not randomized controlled trials, cohort studies, that showed a reduction in colon cancer mortality. For people who are familiar with medical statistics, will realize that observational studies almost always overestimate benefits. So USPSTF has given a Grade A recommendation to perform colonoscopies in all adults aged 50 to 74 based on 2 observational studies quoted above, which most likely overestimates benefits. Furthermore, the decision to lower the age to 45 was based on CISNET data modeling. That is, we don't have any real-world studies in the 45 to 49 age group if colon cancer screening actually saves lives. And what do we get after all these screenings? Per CISNET data modeling, on average, screening allows people to live 3 to 4 extra months. Now again, this is an average. There will be many people who will not benefit at all, while some will gain decades in extra life. And that is the dilemma. Colonoscopy offers no benefit or potential for harm in most, with massive benefits in a lucky few. Remember that USPSTF guidelines are based on 2 observational studies, and my comment that observational studies almost always overestimate benefits? Enter the NordICC Trial, the only randomized controlled trial on screening colonoscopy, which was published in 2022. If you read the conclusion in the screenshot, it appears that screening colonoscopy leads to decreased risk of colon cancer and potentially saves lives. Let's dive deeper. Since you cannot force people to undergo colonoscopy against their will, the trial was structured to compare people who were invited to undergo colonoscopy versus people that were told that they will not be getting any colonoscopy. Out of the people that were invited to undergo colonoscopy, approximately 42% underwent colonoscopy. This slide shows screenshots from the detailed results of the study. Let's apply these results to the diagram from the previous slide to put these numbers in perspective. The rate of colon cancer in the invited colonoscopy group was 0.98% versus 1.2% in the control arm. This translates into a 0.22% absolute risk reduction in colon cancer screening in 10 years. Next, let's look at the risk of colon cancer deaths or cancer-specific mortality. In the invited to colonoscopy group, it was 0.28%, and in the control arm, it was 0.31%. Therefore, the absolute risk reduction in avoiding colon cancer death in 10 years was 0.03%. Now, finally, let's look at all-cause deaths or all-cause mortality. The absolute risk reduction in this case was a meager 0.01% in 10 years. Now, both the colon cancer-specific mortality and all-cause mortality were not statistically significant. That is, if you repeat the trial, you might not see any benefit in cancer-related mortality or all-cause mortality from screening colonoscopy. Now let us compare numbers in people that underwent colonoscopy versus the control arm, as this was one of the major criticisms of the study. The absolute risk reduction in finding colon cancer was 0.36%, and the absolute risk reduction in colon cancer mortality rate was 0.16% over 10 years. Actually, it's 0.15% based on the supplementary appendix. What this means is that colonoscopy reduces the risk of dying from colon cancer, on average, by only 0.16% in 10 years. However, the medical industrial complex advertises 50% risk reduction in colon cancer. That is a statistical technique called relative risk, and the screen shows you how to calculate it. And again, there was no difference in all-cause mortality, that is the overall risk of dying in either the screening or the control arm of the study was exactly the same. So why am I harping on all-cause mortality? I think everyone would agree a real goal of getting all of these tests is not to get a diagnosis, but to actually live longer. The reason why we need to measure all-cause mortality is that we forget that these tests can cause harm and even death. Let's try to understand this concept in a fictional population where 100 people decide that they don't want colonoscopy, while another 100 decide to undergo colonoscopy. Let's assume that in this fictional example, 50 people die of colon cancer in the control arm versus 25 in the colonoscopy arm. This is a massive risk reduction benefit for colonoscopy. Remember from the NordICC trial that the benefit was a meager 0.16%. However, we know that a small percentage of people will be harmed and also die from colonoscopy-related adverse events. Examples include dehydration from bowel prep leading to acute kidney injury, sedation leading to aspiration pneumonia, bowel perforation leading to infection aka peritonitis and sepsis, or anesthesia leading to a heart attack, especially in high-risk people. So unless we are actively looking for these complications in the clinical trial, all of these extra deaths will not be counted in the screening arm. However, once you add all of these complications to the total, the screening program does not look very appealing. This is the reason why we need to measure all-cause mortality in screening studies. Our goal is first do no harm. Now that we've looked at the data, let us look at other problems with colon cancer screening and why it's a bad quality measure. In my prior video, False Positives, Real Profits, I discussed that there are statistical techniques that can give the appearance of efficacy to a test when in fact the test is completely useless. These techniques include overdiagnosis bias, lead time bias, and a length time bias. For people who did not watch that video, I'm adding that segment next. For people who did watch that video or are familiar with these concepts, feel free to jump ahead to the next chapter marker, average risk versus low risk. In a population without a screening program, let's assume that the prevalence of progressive cancer is approximately 1,000 people. We follow these people for 5 years, and 5 years later, 400 are living and 600 died. In this case, the 5-year survival rate is calculated to be 40%. Now let's implement a screening program. In addition to the 1,000 people with progressive cancer, let's say we find an additional 2,000 people with non-progressive cancer using the screening tests. These non-progressive cancers will never cause a problem in the person's lifetime. 5 years later, out of these original 1,000 people, we still have 400 alive and 600 dead. However, since the cancer did not progress, all the 2,000 people are still alive. In this case now, the 5-year survival rate is 80%. We just improved the survival rates of cancer in a population by implementing a screening test statistically without any change in patient outcomes. Next is lead time bias. Let's assume that cancer in a person starts at age 50 and progresses to cause symptoms at age 67, and the person dies at age 70. In this case, the 5-year survival rate is 0%. Now, if we implement a screening program, we may catch the same cancer at age 60. However, the person still dies at age 70. In this case, statistically, the 5-year survival rate is now 100%. All we did was using the screening test is to find the cancer earlier in life, but it did not prolong the person's lifespan. And the last is length time bias. For rapidly progressive cancers, the screening interval may be too short. In this example, a screening program only finds one progressive cancer via screening, and 5 would have become symptomatic even before the person had a chance to undergo screening. For slowly progressive cancers, however, the screening test finds a lot more. In example, 7 out of 10 and 1 slowly progressive cancer, irrespective of screening. This is the central dilemma of screening. For rapidly progressive cancers, the screening interval is too long, and for slowly progressive cancers, it is too short. If we decrease the screening interval, we may find more rapidly progressive cancers, but risk side effects of screening and also finding many more false positives in other people. The clinical studies showing the benefit of colorectal cancer screening were done predominantly in American Caucasians. However, the United States has a large immigrant population with many immigrants immigrating later in life. Most immigrants have a different genetic, dietary, and cultural profile, and therefore the risk for colorectal cancer is different. For example, many American Indians, that is the ones who immigrated from India, traditionally are vegetarian and rarely, if ever, eat processed meat, a known carcinogen. And I belong to that category. Yet, USPSTF applies the same rules for colorectal cancer screening to everyone. I'm taking the example of immigrants, but the concept of individual risk assessment applies to everyone. When performing testing on people without informing them of their risk status, we are doing the exact same thing that the fictional Japanese doctor did to the fictional American, who, in our fictional opening story, immigrated to Japan at the age of 50. Making colorectal cancer screening a quality measure ensures that most doctors will not discuss individual risks versus benefits and will by default perform screening to meet the quality measure. That is, there's no informed consent. This has a bigger impact on doctors who treat low-risk populations such as immigrants, and their colorectal cancer screening performance rates will be worse, leading to financial penalties under value-based care. The look-back period for someone with a prior colonoscopy to meet the colorectal cancer screening quality measure is 9 years. Many people change doctors, insurance, and are moved to different cities or states. In practice, this makes it challenging to find old colonoscopy reports to prove that the person underwent colon cancer screening. However, if insurance companies, especially Medicare Advantage plans, don't have the data, they often mail patients a free fecal immunochemical test, also called the FIT test. Most people don't possess health literacy and assume that the FIT test will decrease their risk of dying from colon cancer. They'll collect and submit the stool sample for the FIT test to the health plan, increasing the health plan's quality score. FIT tests have a very high false positive rate, leading to unnecessary colonoscopies with risk for harm. But MA plans still reap higher profits from CMS as they meet the quality target. This workflow is another example of Charles Per's theory of normal accidents, which I discussed in a prior video, the quality of quality measurement. There's limited availability of gastroenterologists and colonoscopy suites. Screening colonoscopies reduces access to these resources for individuals experiencing symptoms who require diagnostic colonoscopy or endoscopy. Furthermore, health systems in a value-based care contract with significant dollars at risk may prioritize or over-allocate resources to colonoscopy for screening at the expense of diagnostic services. This will result in delays in diagnosing and treating gastrointestinal diseases, including colorectal cancer. For example, in Connecticut, it often takes several months to secure an appointment with a GI specialist. Aggressive cancers often grow and spread rapidly. Let's take the example of a person who just had screening colonoscopy and it was normal. If the person develops symptoms 6 months later, both the patient and the doctor may be hesitant to perform another colonoscopy, as the colonoscopy 6 months ago was normal. This creates a false assurance bias. Even if a decision to perform colonoscopy was made, the insurance company may refuse to cover another colonoscopy. This can potentially delay the diagnosis of colorectal cancer, causing harm and even death in the patient. And there's lack of informed consent for colorectal cancer screening. Once colon cancer screening becomes a quality measure, it puts pressure on doctors to meet the metric, especially if there are penalties attached. Aggressive advertising from large health organizations that colon cancer screening saves lives also generates patient demand. This leads to biased clinical decisions as doctors don't want to be penalized. Given the limited amount during an office visit, patient demand from advertising, and the risk of being penalized, doctors don't inform patients of all the risk versus benefits. That is, there is no informed consent, as the patient does not know all their options. Doctors start treating patients to meet the quality measure, and the quality metric improves. Other doctors follow suit, and when enough doctors start making the same decisions to meet the quality metric, it then creates a new standard of care. The remaining doctors are now forced to follow the new standard of care, as it now also becomes a new medical legal standard, and all doctors want to decrease their exposure to legal liability. And then the cycle continues. The holdouts that want to have nuanced discussion with their patients now have to spend more time during an office visit to explain the pros and cons of colonoscopy and why it may not be the best choice in someone who's low risk or has multiple other medical problems which can cause harm. If the patient chooses not to undergo colonoscopy and due to a stroke of bad luck develops colon cancer, the doctor may be exposed to medical legal liability, even though screening colonoscopy may not have been clinically indicated based on the data that I showed earlier. In real life, this is how it plays out. Many people are unaware of the true risks versus benefits of colon cancer screening and often believe that it unequivocally saves lives. Aggressive advertising from large health organizations reinforces this misconception. This is further compounded by making colon cancer screening a quality measure which disincentivizes doctors to fully inform patients about the potential risks of screening, as patients who decline colon cancer screening will negatively impact the physician's performance metrics, penalize them in value-based care contracts, and increase their malpractice risk. This leads to overscreening and most likely harm in the long term. Now that we understand the risk of colon cancer screening, let's take a look at what PCPs and ACOs can do to meet the measure. Unfortunately, we've been put in this position and have to abide by what the powers to be tell us. CMS recently switched to the Electronic Clinical Quality Measure, or ECQM, for reporting. My understanding is that ECQMs apply to MIPS, Medicare ACO, and Medicare Advantage plans. Commercial plans may still have more leeway in how they accept data. There are still many unknowns, at least to me, on how ECQMs will work when it is time to submit the data for the 2025 measurement year. However, I anticipate that the basic workflows will remain the same. The three most common tests in use today are the FIT test, stool DNA, and colonoscopy. The CPT codes for these tests are either billed by the lab or by the gastroenterologist performing colonoscopy. Yet, the PCP is held liable if these entities send out an incorrect bill or the claim is rejected. The only option here is to send the person for the appropriate screening test and hope that the bill is correct and the insurance company does not deny the claim. If the patient qualifies for a denominator exclusion, for example, has a history of colectomy, then the doctor, such as PCP, oncologist, or surgeon, must bill the appropriate CPT and ICD-10 codes during an office visit in the measurement year to remove the person from the denominator. CPT-2 codes are no longer accepted as part of ECQMs. So all the work that went into implementing CPT-2 codes and training doctors to use them in the last few years was a complete waste of doctors' time. All it served was to move money around in the medical industrial complex and generate profits. Supplemental data submission, at least up until last year, was done in two different ways. Submitting Excel or CSV files with discrete lab values for FIT or stool DNA tests if available, in the format specified by each payer. Manual collection and submission of lab and colonoscopy reports were up to 9 years ago. Manually collecting and submitting denominator exceptions is a big mess, with every plan creating its own rules on what it will and will not accept. Artificial intelligence can help find the supplemental data and collate it for submission to the insurance company. However, this benefits large organizations with a single EHR at the expense of small practices. In conclusion, given the information that I described above, at the end of the day we are left with the following. Colorectal cancer screening probably does not work in average risk people and most likely causes harm in low risk people. Most people believe that colorectal cancer screening saves lives and they want the test. I think most of you will agree with me that colon cancer screening should be an informed choice by the patient, and a quality measure is not the way to do it. You can find a written version with references to the material and an audio podcast version on pcplens.com. If you like this video, please sign up on pcplens.com so that you don't miss the next episode when it's published. Thank you for watching this video. Take care and goodbye.